Buenas tardes a todos a nuestra nueva edición de un Meet the LExpert, conociendo al experto. Esta vez tenemos un invitado directo desde Brasil, desde Río de Janeiro. Con nosotros está el doctor Ruddy Dalfeor. Did I pronounce your name correctly?
Perfect.
Ruddy es hematólogo, trabaja en DASA, Oncología, en Río de Janeiro, Brasil. Y es embajador brasileño de la Society of Hematologic Oncology, Houston, del MD Anderson, que hacen un meeting que siempre estamos viendo con envidia ahí. Por lo tanto, queremos que nos cuente un poco de él, de dónde trabaja, de su rol como embajador de esta sociedad, y por supuesto vamos a, digamos, fluir en relación al linfoma del manto desde diagnóstico, tratamiento y cómo aplicamos la nueva evidencia que ha venido apareciendo en el último tiempo en Latinoamérica. Y agradecemos mucho a Ruddy que haya venido. Él habla un poquito español, pero prefirió que hiciéramos esto en inglés. Así que esto es un desafío porque la próxima vez que te invitemos, esto tiene que ser en español, pero esta vez vamos a seguir en inglés. Very welcome, Ruddy. Thanks for coming. And I want to hear about you.
Hola a todos. Pido desculpas por mi español, pero definitivamente preferirás que hable inglés. I really hope you can understand, and I'll try to speak slowly. But my Spanish is not that good, especially when regarding to like hematology terms and disease aspects. I can understand you completely well, so if you want to ask in Spanish, there is no problem at all.
Okay.
But if I try to answer you in Spanish, it will be a mess. So I'll work on it, I promise. So I'm from Rio. I did all my residency here in Rio. We have university hospitals in Rio. We have like 2 of them. And I did my hem formation in both of them. So hematology, I was in the State University Hospital in Rio, and stem cell transplant in the Federal University Hospital of Rio. I did some time in MD Anderson. I spent some time there. I was at leukemia with Cantarjan and all those remarkable staff over there for 2 or 3 months. And then I came back later for cellular therapy program, focus on cellular therapy treatment. So CAR T cells, especially CAR T cells and CAR NK cells. With Katie Rizvani and colleagues. And then I moved back to Rio, and now I work in the private setting only. But we are trying to expand our clinical research program so we can help the public institution as well. So my main focus here is to get as many clinical trials I can, so I can try to give back to those places I learned so much about hematology, and perhaps helping treating some patients in the public, but in a clinical trial setting. So hopefully we can arrange that. And SOHO, it's new in my life. I was nominated by Professor Verstovsek. He indicated me for Professor Contagion.
Can you explain what the Society of Hematological Oncology is, please?
Yeah, definitely. So it's a society founded by the folks in MD Anderson. So it was Professor Freireich, Contagion, and Michael Keating, who started this society. And their focus is to spread the knowledge and facilitate to us hematologists to incorporate all these absurd informations we gather in like ASH meetings and EHA meetings. So their annual symposium is held in Houston, and they have only one room, and they have the main experts in each area. So you have like Loretta Nastopil or Carla Cazzulo presenting follicular lymphoma. We had Toby Ayer for diffuse large B-cell lymphoma. You have like Dryling, I guess, once spoke about mantle cell. So Simon Rule in the first editions. So those kind of guys telling you what do you really need to use in your practice regarding all the oncology disease. So it's really straightforward and pretty direct for us. So I mean, because we are flooded with information in all those meetings, and sometimes things are years ahead of us, and they try to give us, I mean, what diagnostician tool we should implement in our routine, the new regimens that should go for standard of care. So it's pretty straightforward. It's a really interesting meeting, and their focus is to expand their program and spread knowledge and to facilitate that work. And that's why they invited me. I mean, I'm still young hematologist, so the idea is to plant the seeds in young hematologists here in Brazil and try to develop research and collaborations with them and other institutions like we are doing now. So this is kind of part of the idea as well. So Gustav Sek nominated me, and Kantarjan kindly invited me, and I'm truly honored to be part of this.
Oh, so you are like an ambassador of continuous medical education then?
Yeah, I try to.
Great. How is the diagnosis of mantle cell lymphoma made? Just the biopsy immunohistochemistry? Do you have cyclin D1 as FISH or some other strategy?
Yeah, we try to biopsy all those patients. I mean, leukemic non-nodal we do by flow cytometry, but the most of other patients we try to biopsy all of them. We try excisional biopsy as much as we can, so the pathologists have more material to work with. Regarding immunohistochemistry, we have cyclin D1, but we don't have cyclin D2 or D3. We have SOX11, but usually if it's cyclin D1 positive, they don't use SOX11 stain because it's a little bit expensive and you already have the diagnosis, even though we know those patients have slight high risk features. But if it's cyclin D1 positive, usually they don't complement with the SOX11 testing. And this is cyclin D1 negative, then they try the SOX11. But we usually don't have cyclin D2 or D3. And in P53, we have to request the immunohistochemistry for performing. And the FISH, it's really rare for the insurance to pay. So usually we try to have the patient paying for FISH if necessary, but usually we conclude the diagnosis with cyclin D1.
Yeah, so most of the diagnoses are with the biopsy, just biopsy and immunohistochemistry. Okay. Yeah. And then for staging and risk assessment, risk profile of the patients, what do you do?
Yeah, usually we do PET-CT. PET-CT is easier. I mean, I don't recall patients who didn't have access for PET-CT with mantle cell in the private setting in the last 2 or 3 years. Sometimes the only issue is the time for the approval when performing the exam. Like sometimes I had a patient recently. It was not MCL, it was DLBCL, but he waited for like 2 months to get his PET-CT. So from the diagnosis to do the PET-CT, so he was post first cycle. I mean, he already started, but that's another issue. But usually we do PET-CT. I don't do colonoscopy and endoscopy for all those patients. I mean, if they have like intake in the GI, I assume they are infiltrated. Except they have a lot of symptoms and the PET-CT doesn't sparkle anything in the GI, then probably I will go with colonoscopy. Bone marrow aspiration and biopsy, I rarely do. Except with, I guess the only exception is it's real low counts that I'm considering like overlap of lymphoma and MDS or something like that. But we try to do only with PET-CT. I had one patient that he came to me with the diagnosis after the colonoscopy. So he was for his, it was his first colonoscopy, completely asymptomatic, like over 50 years. And those patients usually do colonoscopy like for rectal cancer. And they find out he has MCL. And then I proceed with PET-CT for him. But on the contrary, it's really rare for me to request that.
And if the patient has any of the high risk features, do you go and check the central nervous system?
Well, only if they have symptoms. If they don't have symptoms, I don't do like routine MRI or lumbar puncture in these patients, even though like they have like low iron intake in the PET. If they don't have any symptoms, any neurological symptoms, I usually don't perform a lumbar puncture and MRI.
Great. Well, I assume most of us at the beginning of the diagnosis of mantle cell, we have treatment in mind. We want to treat the patient, but there are a few small percent. Well, easier with the leukemic non-nodal variant, but some of the nodal also can be observed for a while. Do you do that in some cases? No, how do you assess that?
Well, actually, I'm a pretty huge advocate of not treating the most patients I can, especially with metal, especially with indolent lymphomas. I mean, most of these diseases are incurable, so you can't cure these patients, most of them. And we know that treatment for mantle cell usually are aggressive treatments. So if I can wait to begin this treatment, I try as much as I can. So I have like in my mind 3 or 4 patients that we are not treating, and the longest time they have in watch and wait approach, I guess, is 2.5 years, the longest one so far on these 4 patients. This patient I told you that had the diagnosis on his colonoscopy, he only have this GI disease. So I did his PET scan. He has like 3 or 4 intakes in his GI. He has no symptom whatsoever. I end up doing the flow cytometry on the peripheral blood, and he has some cells, circulating cells, but this patient I'm not treating, and the other ones are leukemic non-nodal. But we have one that we could wait to treat him like for a year and a half, I guess. I don't remember now. It's my boss patient. So we could manage to wait a long time to treat some patients. So in metal, and in indolent lymphomas in general, I try my best not to treat those patients, only if they are symptomatic. And even if you consider like MIPI score, I have this other patient. He's leukemic. He has some nodules on his PET-CT, but there's no enlargement, just intake in the PET-CT. And if we would like assess him on MIPI-C, he would be a high-risk patient, and he is now over a year in observation. So if we have to have better criteria to assess those patients, because that's it. You have a MCL diagnosed, you have MIPI-C high-risk feature, but the patient has no symptoms whatsoever. He has like some low counts, but his platelets are holding like 100 for a whole year, 100,000, and we're still just watching these patients. So I really suggest and try not to treat all patients with MCL.
I very much agree. I like to spare patients from treatment if they really don't need that. Overall survival and health-related quality of life are my end goals, and I hope all of us follow that. So the idea in lymphoma experience is we have to blend the evidence with the experience of our experts. So I would like you to give us your overview of the first-line treatment as how you do it in the real life, how do you practice at DASA Oncología, and what do you think you will be able to incorporate of the new things that have appeared? I'm talking about SHINE, I'm talking about Triangle. What are your thoughts about that?
Yeah, I mean, thankfully in the private setting we have access to a lot of drugs. It's not easy access, but we have access. And middle is pretty tricky because, as we were saying, there are some patients that you don't need to treat. There are some patients that you can treat with low intensity treatments, and there are few patients, thankfully, that you have to be pretty aggressive on the treatment. They have pretty aggressive disease, and then you have to step up your game and treat them aggressive as well. So I'll start with more frail patients and elderly patients. We have a bunch of first-line regimens and studies conducted to those population, and I mean the standard of care now. So we have VR, R-Square, R-CHOP, VR-CAT, R-BAC, 500, and those trials, they have like overall response rate in their 90%, and complete response ranging from 40 to 60%, 30 to 60%. And as we were saying, those patients, you cannot cure them. So I think if the patient is frail and you have a good rescue regimen, there is IBTK. In more frail patients, I try to not go too hard on them. So I don't think our CHOP is wrong. We try to give them Benda, first line, BR. I'll give a link to Shine in a bit. I never used VRCAP, but I think it's interesting data, but more toxic, I guess. But usually for frail patients, I try to use R-CHOP or BR with a slight preference on BR. We have the Rummel trial in indolent lymphoma that favors BR. I know this trial is polluted with follicular lymphoma patients, marginal zone lymphoma patients, but they have male patients in those registries. So I try to use BR for those patients, but it's not easy access for BR in MCL here. So some insurance don't cover, and we have to go with R-CHOP. And first line, and now is the tricky one, because we have triangle, and you have multiple trials. You have like going from R-CHOP alone to hyperCVAD like regimens, and all of them you have like over 90% of overall response, and most of them range from 80% of complete response. And I mean, hyperCVAD you wouldn't need transplant, but I don't use hyperCVAD for MCL. Usually we were doing only rituximab and DAP or Deox. We switch cisplatin for oxaliplatin. We don't intercalate this with R-CHOP. We try to give the least chemo for those patients because we were transplanting them. And I did transplant a lot of MCL patients. I mean, in my residency, in my practice, and recently, since Riley present the ASH triangle data, we didn't have any young patient with MCL. But I really hope we could eradicate stem cell transplant in first line for autologous stem cell transplant in first line for MCL, because the data we have that support this approach was not good. It's not a good data. I mean, I know it's a good data for the time, but it's early 2000 trial. You have less than 30% of patients who received rituximab. They were induced with only CHOP. The majority of them, only less than a third of them receive R-CHOP. And the comparative arms, I guess, was CHOP again for consolidation and interferon maintenance versus BEAM with CyTBI autologous transplant. And I don't think it's good data if you see what we have now. I mean, we know now that cytarabine is really good in these patients. We know that rituximab changed the game for all lymphomas, including MCL. We know with data that rituximab maintenance improves overall survival and PFS in these patients. But I don't think that the transplant would benefit those patients. And this is what we saw in triangle. And right now, I won't say I'm hoping I find a young MCL patient, because we know the struggle we face with these patients. But I guess if I face a young patient with MCL, I would definitely try to do triangle and avoid transplantation in these patients.
Okay, so I see
I don't know if you want to comment something.
Yeah. So I see you are very tempted to follow the triangle path, and Latin America is waiting for the article. I do not like the fact that has not been published yet. And when it was presented, the failure-free survival endpoint, I think it was a bit confusing. So I'll reserve myself that when we analyze that in fase 3. But I wanted to take you back to the earlier comment about bendamustine rituximab. At our group, we have like some different thoughts about our experience with bendamustine rituximab in mantle cell, especially because older patients could suffer from myelosuppression with the bendamustine. I have had a pretty good experience, but I have colleagues of mine that have not had that good experience. What has been your?
Well, we have some good experience with BR for MCL. Good experience regarding toxicities. I mean, we have some patients that relapsed early. I remember one patient that was refractory in the middle of the treatment. He progressed disease. But regarding toxicity, I don't remember any negative aspects. We have some really old patients that did very well with BR. So I don't see a problem indeed, except for access. Sometimes we don't have access to BR in MCL.
Do you decrease the dose in older patients?
Yeah, I try not to, but if they are like cytopenic for a long time, if you have to keep delaying the next treatment, the next cycle, then perhaps you could decrease. We don't have like a standard decrease protocol. So I remember one patient with follicular lymphoma, we just did 1 day of bendamustine, 9 milligrams. Actually, 2 patients of follicular lymphoma, we did this approach, doing only 1 day of bendamustine. And the other patients, that there were one patient but was not MCL, he received like the 70 milligrams 2 days dosage. So perhaps I would do 90 1 day just for convenience. I mean, patients don't have to come back the other day. But usually we don't do it.
Yeah. At our center, when we have that problem, we hospitalize patients for receiving the bendamustine day 1 and day 2, like a brief hospitalization. Okay, so we talked about your induction regimen for fit patients. I understood you do the mixed R-CHOP, some platin cytarabine.
No, actually, we try to omit R-CHOP. We try to do only RD-HEP or RD-AOX because we try to give less chemo as we can. If the patient is going to autologous, so we try to go straight to the transplant. So we avoid him receiving anthracyclines in the R-CHOP, cyclophosphamide, toxicity. I mean, it's not that common, but we have some issues with cyclophosphamide previously, like cardiac dysfunction and pulmonary disease after cyclophosphamide. So if the patient is going to autologous, we try to do only RD-HEP and go straight to auto. But in the light of triangle, I don't know what we're going to do anymore. I would ask Perini if he was here.
And did Shine change any of your practice or taught you anything about the treatment of mantle cell?
Well, actually, Shine, I'm not criticizing the study. I mean, I know some people went really hard on the protocol, the way it was designed. I think at the time they did this protocol, it was fantastic thought, but I have strong criticism with the results. I mean, they achieved the PFS endpoint. It's way superior, but if you think about the patients who progress on BR, they will receive, in the real world, they would receive IBTK post BR, and they probably have the same OS. And the study showed us that they have the same OS and more toxicity. So as we discussed previously, it's a incurable disease, frail patients, toxic treatments. If there is no OS advantage, I don't think it's good enough. And I mean, we have to consider cost. I mean, ibrutinib is pretty expensive, especially continuous IBTK. If you think about those patients, they receive IBTK for 8-10 years, and if you don't get OS advantage, I don't see the real advantage, because after they would still receive IBTK therapy, so it's not financially better. It's not safer, and you didn't give us OS. So Shine, it was a really good study. I mean, we have, I guess it's ECHO, the name of the Acala trial. It's the same trial with acalabrutinib. Maybe if this is more safe and tolerable, perhaps we're going to see a trend in better OS. I know AstraZeneca guys are really excited about this trial, so perhaps we're going to see a different result. I don't know if this will change my practice, but it was a really good trial for us to comprehend more about the disease and its follow-up, but it didn't change my practice.
Great. So I'm guessing you do rituximab maintenance for most of your patients.
Yeah, after COVID, the only disease I'm still using rituximab maintenance is MCL.
Oh, so you do not do
lymphoma.
follicular?
Oh, there is only one exception if the patient didn't have a very good response in his induction treatment in follicular, then I would consider doing rituximab maintenance. But in follicular, we are not using anymore. I mean, our team. I think it's the rationale is pretty strong. We have PFS benefit, but we don't think the toxicity make up for the big scenario. I mean, okay, we have access because we have insurance paying, but I don't think it's economic advantageous for us to do in follicular, except in this rare cases.
Okay, and since most of your first-line treatments are chemoimmunotherapy, I'm thinking second line is a BTKI, right? So what
Definitely.
types of BTKI do you have access at Rio de Janeiro at DASA Oncología?
Yeah, we have the three of them. We have acalabrutinib, ibrutinib, and zanubrutinib. Thankfully, and my second line treatment for mano is IBTK. I mean, I can argue with the gods. So I remember one lecture, Simon Rule was pretty straightforward, saying that if you don't do IBTK in second line, you are doing it wrong. And there is another lecture of Dryden saying that his standard of care in second line is IBTK. So who am I to think different than these guys? So IBTK is our goal
But the question is,
treatment.
which one?
Yeah. So actually, we don't do ibrutinib anymore for ibrutinib monotherapy. We don't do ibrutinib monotherapy for any patients anymore, even in CLL. We are using most patients are on acalabrutinib, and we have a small subset of patients on zanubrutinib. I actually don't see a difference in those two drugs. My experience with acalabrutinib is really good. We have a lot of patients using it, but with zanubrutinib, I guess we have 3 patients, and they are doing really well. But I mean, it's our experience. So I mean, we are more used to Wakala, so we tend to go with Wakala, but ibrutinib we are not using anymore. I heard the topic on CLL you guys just released in the podcast. So we don't use it ibrutinib except for clinical trial. I mean, we have the Brewing trial open in our institution.
With
there is pirtobrutinib, pirtobrutinib versus IBTK, other IBTKs for salvage therapy in MCL. So perhaps some patients in this population will receive ibrutinib per protocol. So we use in this situation, but other than that, we are using Acala and Zano. And I don't know which one of Acala or Zano is better. I mean, I think they are equal.
Hey,
what's your opinion?
I pled the fifth. No, I have most of my experience with zanubrutinib. So at my center, we do most Acala for CLL, and for mantle we are using zanubrutinib. But I think that the game is on there. We need head-to-head trials. This is a need.
We will never have.
We will never have them. Yes. Okay, and after that, is there anything after that? What can we do? What do you do? I probably think you do not have access to other kinds of therapies yet. CAR T for mantle cell or something like that.
Well, besides praying a lot, what I usually do, not do because thankfully I didn't face that many cases of relapsing after IBTK. So we have some patients who progressed. One thing we did that worked really well as a bridging therapy is with add-on venetoclax. So we had this patient, and she came to us progressing in ibrutinib, and we were trying to enroll her in a CAR T trial. So we reached out to Arnold Nagler in Israel, and they had a trial there. It was like 2 or 3 years ago. And so we add on venetoclax and high-dose dexamethasone, like weekly, just like myeloma. We did this based in voices in our heads, but it worked pretty well. The patient had like a real large spleen, some cervical lymph nodes, and they all shrank really fast with this approach. So it was ibrutinib, venetoclax, and dexamethasone. And we sent her to Israel, but as soon as she landed there, they withdrew the ibrutinib, and she had progressive disease in CNS. So I was reading at the time that maybe ibrutinib protects the CNS from the infiltration, even though the patient progressed in ibrutinib, it helps the action of venetoclax and perhaps protects a little bit the explosive progression. So I wouldn't advocate on you interrupting ibrutinib and then starting venetoclax. I advocate you to add on venetoclax and use it as a bridge, because the data we have suggests that those patients will progress fast. Other thing we used was the RBAC, so bendamustine, cytarabine, rituximab, as a bridge as well. So the patient did good. They have really good response and really fast response. We tried to allow him, but we couldn't. And the one thing that I would really like to point out, I mean, I'm really advocating us to stop autologous treatment in MCL, but in the contrast, I'm really advocating us to always consider allogenic stem cell transplant in relapsed MCL. There was this session last year, Dryden was the host in EHA, and I don't remember the name of the guy from EBMT, and I really like to remember because he was a wonderful speaksman. He was really good in his lecture, and the data for allogenic in Meno is pretty good. We have some flat lines. I mean, we are curing MCL with allogenic stem cell transplant, and as soon as we can transplant them, the better is the outcome. So if you, I might be wrong, but if those patients that were referred to allogenic in second line, I guess their curves are around 60%, 60 to 70%, and after 3 years is a flat line. So
so you would go in second line allo for mantle cell lymphoma?
High risk patients like P53, blastoid, but for those patients, I would really go for allo. I have a patient now, she's third line IBTK. She's on Acala for 2.5 years now. And she's wonderful. She's in complete remission. She's way over the expected line for her. Well, she's 3.5 years, I'm sorry. That's why she's over the line. If we use the trial as the comparative data. So she's 3.5 years, and we finally convinced her to go for allo. She's 65 years old, completely fit, and we are trying to transplant her as a curative approach. So I still think allogenic is really, really valid in mantle cell lymphoma.
So, you know, I was going to tell you an anecdote. I had this year a patient that was high risk blastoid, high LDH, Ki67, the whole thing. He went through 4 lines of therapy, 2 IBTKs, nothing was working. We enrolled them in a trial with silobertomab vedotin. He had a response, but a very short duration. And then I went like trying obinutuzumab venetoclax, and I had some very similar experience. He started responding clinically, but he did had a cerebrovascular attack. I could never find out if he had disease. Did I lose you, Ruddy? Oh.
No, I'm still hearing you.
We had a moment. We had a moment, but we're back. Okay. So after that, he did not want any more therapy, and I could not really diagnose it. He had a CNS disease, but you got me thinking that well, that could have happened, and in the meantime, because he had stopped IBTKs. So that's a nice observation. Maybe we will see some data about that in the future.
Yeah, even in the zilovertamab, there is a zilovertamab trial that they combine it with IBTK, with ibrutinib. I don't remember if the patients received ibrutinib previously, but the responses were higher in the patients in the combination with zilovertamab vedotin with ibrutinib, comparing to zilovertamab monotherapy. So you go like for like 40% overall response rate to like 80% overall response rate if you add ibrutinib to zilovertamab. So perhaps ibrutinib help the environment. I don't know. We have some data in ibrutinib and CAR T cells for CLL. All the patients in this trial progressed IBTK, and they received IBTK previous to the CAR T infusion and after the CAR T infusion, and the responses were better, even though they progressed on IBTK. So perhaps ibrutinib do some magic with other drugs and improve responses.
Great. Okay, Ruddy, we thank you a lot for taking your time to talk, for talking to us, for participating with us. We see you a lot in social media. You have been a source of support in Rio de Janeiro. We really want to go. It's a very beautiful place. And we hope you have a great time in Sao Paulo at the HIMO. And we hope we can meet you soon here at Lymphoma Experience.
No, I can't thank you enough for the invitation. I'll work with Perini to bring you guys to Brazil, because he's the powerful one here between the two of us. So he has more power to bring you guys to Brazil. And of course, we will try to have you in Rio as well. And I'm really looking forward to meet you guys in Chile as well. I mean, it's really great to see the work you guys are doing in spreading the knowledge in lymphoma, and trying to integrate Latin America as one. I think we continue with this program. I mean, you leading this as you are leading, perhaps we can do something big and try to get more access for clinical trials and drugs and everything. I mean, this initiative that you guys have is pretty remarkable, and I really like to congratulate you guys to developing this and to trying to integrate people from all over Latin America. I know you have some work with Professor Castillo and with Perini. I mean, hopefully we can try to do something together as well, like scientific, like writing papers, registries, clinical trials. So you guys initiated a pretty remarkable initiative, and I really hope it improves and get bigger.
Yes, we have some ambitious plans about that. And we are looking collaborators all around Latin America and the world. So everyone is invited. We can put the place, and everyone can come, drink, and talk about lymphoma. So thank you again, Ruddy, and we will see each other soon, I believe.
I'm counting on that.
Okay, have a nice trip.
Thank you.
Bye.
Ciao, ciao.
Ciao.
Abrazos.